few people just kind of joining us, but I have a few minutes to talk through. I'm not that important, so I'll just get started on what I was hoping to say. So I'd like to welcome you all here today. So my name is Chris Crockford, and I am a research officer with the Irish Cancer Society. So I'll be chairing today's talk as part of our 2020 Cancer Week. So Cancer Week Ireland was devised and set up by the Irish Cancer Society and Trinity College Dublin in 2014 as a way of opening up the national conversation around cancer. And this year we've had a series of talks on cancer research and around living well with and beyond cancer. And for the first time, obviously, we've gone digital. So bear with us if there's any technical difficulties along the way. So today I'm absolutely delighted to say that we are joined by Yvonne Hanhauser, who is going to talk through her Irish Cancer Society funded project, the development of a risk reduction patient decision aid toolkit for women with a BRCA gene mutation. So Yvonne has worked in oncology nursing for over 20 years. Forgive me for saying Yvonne.
Okay.
And so she has a higher diploma in oncology nursing from UCD, an MSc in health sciences in advanced nursing practice from NUI Galway. And Yvonne currently works as an advanced nurse practitioner with St. James's Breast Care. In case anyone's unfamiliar with that role, an advanced nurse practitioner is the highest clinical role for nurses in Ireland. So we're very lucky to have Yvonne today, given how incredibly busy she usually is. So Yvonne, just before I hand over to you, I just want to run through a couple of housekeeping notes for today. So if anyone would like to ask questions, and questions are completely welcome and encouraged, there is a little Q&A box down the bottom. So please type in your questions and Yvonne will be happy to answer them at the end of the talk. Now, Yvonne won't be able to answer any specific or individual medical questions. So if you do have any questions like that, we'd encourage you to contact your own oncology or medical team. And we also have an Irish Cancer Society support line that you can contact if you need to. And the number for that is 1800 200 700. So without any further delay, I'd like to welcome Yvonne to begin her presentation.
Hi, everybody. Thank you, Chris, for that lovely introduction. Do feel a little bit old, but anyway. So like I say, I'm an advanced nurse practitioner in St. James's Breast Care Department. And just to say thank you to the Irish Cancer Society for asking me to present this project that we're currently undertaking, and hopefully it will be of interest to you. I'm going to go through the project as much as I can, and also, again, as Chris highlighted, this project is very exciting for us, and we're fortunate that it was funded by the Irish Cancer Society through a nursing research grant. So again, a big thank you for that as well. So I will get going with the presentation, and yeah, so this is a very different format for me, so bear with me. I'm sure it will all be fine. Technology is a wonderful thing. But if there's any questions, I'm sure it'll be fine for the end. I'm used to people stopping me halfway. So basically, what I'm going to touch on today is really the background and the rationale for this study. In other words, you know, what prompted us to think of this as a need in our clinical area. And as I say, I work in James's. It's a breast care department, but we do have a very large, probably the largest nationally, of the high-risk family history clinic that there is with high-risk women and also BRCA carriers. So I'll be looking at the background, why we felt the study was important, the rationale for it. I'll touch on what it means to have a BRCA gene mutation. Very briefly, it's not a very long talk, it could go on a lot longer. And also the other things I'll talk about a little bit is risk reducing strategies and surveillance options, very briefly again. And then finally, I'll kind of talk a little bit about the study so you can get an idea of what the study is, how we're going to do it, and what we hope to achieve from it. So I will get going on all of it now. So the background and rationale, really, obviously breast cancer accounts for 25% of all new cancers diagnosed, and it is in the fifth in the leading causes of cancer death. For that reason, you know, we feel strongly that prevention is a huge part of cancer care, and it is coming across much more in all the cancer documents that we have now. So much research in the past has been focused on treatments and aftercare. So this one is really a prevention, and picking a group of women that this is very relevant for. So prevention strategies, they aim to reduce a woman's risk of developing breast and ovarian cancer by means of prophylactic surgery or risk reducing medication. And that's from the NICE guidelines, and we would actually follow the NICE guidelines very much so in our service. They're UK based, but they're very, very evidence based, so we find them really helpful. Again, from clinical expertise and from working with women who are BRCA carriers, these women often struggle. And I would also highlight that the clinicians also can struggle, and I don't mind saying that, with the choices about interventions. So they're the kind of reasonings behind, well, what would help in this sort of situation. So again, women with BRCA1 or 2 mutation, they do have an increased lifetime risk of breast and ovarian cancer. And just quickly to highlight in the next slide, I'll talk a little bit more about the differences between the 2 genes. Because I think that also is a reason for why this tool was thought of as being really helpful, because it's not like one size fits all. There's lots of various factors, and we can see there that in BRCA1 and BRCA2, there's a slight difference in the penetrance of the gene, and these statistics are sort of thrown out there quite easily on all the things that you look up. But then BRCA1 is about 60 to 90% lifetime risk, BRCA2 slightly less, 45 to 85%, and then ovarian, again, slight difference between BRCA1 and 2, ovarian 40 to 60% in the BRCA1, somewhat less in BRCA2, 10 to 30%. As like I said, we have the largest family history service in Ireland. At the moment, we have roughly about 273 BRCA carriers, but that is increasing all the time. That's my last statistics. I think we are closer to about 300 actually at the moment. So we've got a large group that we would see here. Again, just to kind of go through the genes that we know probably the most about. These slides are actually from the Marsden, again, very nice guideline driven slides, but again, it was the same sort of statistics between BRCA1 and BRCA2 for the breast and ovarian cancer lifetime risk, which I just mentioned. Then there's some differences with the men who are carriers of BRCA1 and I think and BRCA2, so I think if there's men out there, we don't want to ignore the men that carry this gene. So in BRCA1, their male breast cancer risk is very much similar to the general population actually, but in BRCA2, there is an increase in male breast cancer up to 10% compared to the general population. Male BRCA1, similar to the general population with prostate risk, but it can go up to 25% in BRCA2. And those are the sort of things that come up for women when they're looking at their family members, if brothers test, or, so not to be ignored. Women who develop breast cancer where they have a genetic mutation, there is considered about 50% chance of developing a contralateral, a second breast cancer in the other side. And that would be similar for BRCA2 as well. Okay. And this is just a very simplified graph to show that sort of what those sort of statistics mean in comparison to the general population. So you can see the significant increase in breast and ovarian compared to general population. That is a very simplified graph. It doesn't really, I mean, you'll talk to a lot of geneticists now and they're not that happy anymore with these sort of general statistics that come out there, because we know there is variances within these genes. Why do we see a lot of ovarian in some families and not in others? So there's things we just don't know. And hopefully in the future, these more general statistics won't be bandied around as much because there's other genetic influences that they can find now. There's SNPs, protective genes. Why do we see lots of cancers in some BRCA families and not in others? So again, like I say, there's not a lot. There is a lot that we don't know, sorry, but we do need to get more of that evidence in place. But it's just a simplified view, just to kind of capture those sort of statistics. And I think at this point, it's good to say that it's not all about statistics. And that's, I think, probably another background to this, that there's definitely other factors that come into play when women are looking at what their risk is and what should they do about it. And one of the things is age, and again, we know that that's a very important part of where your risk is. So a woman who's a BRCA1 carrier or 2 at age 18. Her risk is very different to when she's 47. And these are the sort of things that come up over and over again that we want to try and incorporate into a decision aid to kind of help with those decisions, to put things into perspective. Family experiences are really important, hugely important. So what women experience through other family members of their experience with cancer, that can have a huge impact in what that person feels about carrying a mutation or what they want to do about it. They may have very definite ideas. I don't want to do the surveillance. This is what happened in my family. So they are huge factors that we hope to capture in this study, particularly because we are hoping to really involve the women themselves within the research. Life choices, I think, they're another big factor. Preferences, you know, when are you going to have your children? Do you want children? At what age? Coping with the surveillance and the risk reducing options is a big thing. Some people are very sure of what they want, and other people it's a bit of a dilemma of what they really want and when should they do it, and timing is a big thing. So kind of what the options are, again, I'll just briefly go over these. This could take longer, but I'm going to try and cover it as quickly and as helpfully as I can. So when women come to our service, when I see someone, I think I really discuss really the two main options being screening, or probably the better word, surveillance option for breast or ovarian, and then there's the risk reducing options. So they're the two main ones. For breast, it's a little bit more straightforward because we can talk about surveillance in that we would look at mammography and MRI as a really helpful tool and a very, very good surveillance option. We get women to do self-breast exam because I think that's important, that they're breast aware. They can certainly find changes within the breast in between imaging, in between clinical visits. So I think that is important. They have access to us if there is any change, and that's important. And we do clinical breast exams. The surveillance and the screening side for ovarian, probably is a lot of people that are tuning in are probably quite aware of this, but unfortunately there isn't as good an option with ovarian in that they haven't really found an intervention or a surveillance method that picks anything up as early as we can with breast. So unfortunately, they've done lots of studies with transvaginal ultrasound and the CA125, which is a marker in the blood, a tumour marker, haven't really been able to get the same outcome. So unfortunately, it has got limited usefulness. And that has an impact on them when we talk about risk reduction. The risk reduction that's commonly used for breast is the mastectomy, usually with immediate reconstruction is preferable. For risk reduction in the ovarian setting is you're talking about oophorectomy. And because of the limited usefulness of the surveillance, there tends to be a leaning towards risk reduction in that way to improve outcomes for the ovarian risk for BRCA carriers. You'll notice then that I've got chemo prevention in both breast and ovarian. I have them there. We hope that they will be investigated more in this research and into the tool. It's not a very utilised option, certainly not in Ireland, from my experience. Nationally even, or even in mostly Europe. You see North America will use chemo prevention quite a bit more and quite a big uptake in it. So I'm not sure if it's just that it's not discussed enough, if it's not the way it's sold, but we don't see it used as much in our setting, but that may change because there's some benefit from it. Very little risk reduction in chemo prevention for the ovarian. The oral contraceptive pill has been shown to have some protection, but I don't see much uptake with that in any setting really. So the oophorectomy seems to be the better option in that scenario. So just to kind of synopsis there is within our high-risk surveillance, they're the main things that we discuss. The surveillance modalities with imaging, clinical exam, the breast risk reduction surgeries come up quite a lot. The timing of that is really important. We do send our women to gynae for ovarian surveillance. Like I said, it's limited usefulness. There's a small amount of evidence that there is some benefit to it. So rather than do nothing for us in our service, we would send our women to the gynae service, and they do transvaginals, but the women are very aware that there is limitations to it. So that's important that they do know that. And then the oophorectomy is something that comes up at the right time. And so that's kind of just a synopsis of what goes on with us. Those risk reduction strategies, this is just a little kind of overview of them. The first one I have there is the chemo prevention, which would be the use of tamoxifen, and there is thought to be about 50% reduction with the use of that as a modality of reducing your risk. Like I say, not utilised as much. Obviously, we're more familiar with the risk-reducing mastectomies and oophorectomy, and you'll notice there's two columns for the oophorectomy. The evidence would be that if you do have an oophorectomy before menopause, or before 40, some literature will say, but before the menopause for sure, you can get anywhere from 50 to 68% risk reduction for breast. Obviously there's the risk reduction with the ovary, but this is, you're also getting some breast risk reduction by carrying out that procedure pre-menopause. And then the oral contraceptive pill, I have it there, and it's, like I say, not utilised as much, but again, we're hoping this is the sort of evidence that we'll be looking at for the actual decision aid when it's being developed. So I'm kind of getting into the actual project itself now. I've gone through the background, why did we feel it was important, and it's for a variety of reasons that can be quite complex for women. So for this project, what do we want to achieve? What's our aim? Well, it's to develop an easily accessible web-based risk reduction patient decision aid for women who are carriers of the BRCA gene mutation. Our objectives: establish a project governance, oversee and manage the project. That's our core research group. So we've kind of got getting going with all of this now. We need to specify the evidence and content to populate the decision aid. So that means we want to look at what is the evidence out there, and we're looking at two things really. Obviously the evidence for what are the best risk reductions, and what does it achieve? Is there any harm to them? This is the sort of evidence we really want to get on top of, but we also want to look at different decision aids and what are the best ones and what way should we build this. The next step then is to develop and test a prototype of the decision aid, and then by the end of this we would hope to produce a decision aid that's accessible, acceptable to the women and the clinicians. Like I say, it can be used within the clinic and it will help to guide clinical decisions in the clinic as well. It needs to be feasible, usable by the women and clinicians in practice. So basically, how are we going to do it? So the methodology is a research term, but that basically means how we're going to do this. And we are using a mixed methods approach, and I'll just explain what that will involve. And it really is, again, like I say, setting up this project management team, our core researchers. I probably should have said at the beginning, it's all over the slides, but this is a joint project between St. James's Hospital and with our colleagues in the nursing department of Trinity. So that's the focus of the research team. It's both clinical nurses and nurses from the nursing department in Trinity. And that's our project management group. And we will also have advisory groups with expert opinions, patient involvement, advocacy groups. So we have an advisory group section as well. Our next step would be the needs assessment. Probably the main element of that will be the focus groups with the women themselves who have BRCA gene mutation without a history of breast cancer. They're unaffected women, and we're looking at preventative care here. Healthcare workers, experts in the field, other stakeholders, meaning policymakers, charity organisations, advocacy groups. So we're trying to get a really broad picture of what the needs are out there. Evidence synthesis will be us looking at what the literature is, like I say, talking about the type of decision aids that are already out there, looking at the evidence about risk reduction measures. Edelphi is a process that we will use to achieve consensus on what we actually come up with from the research, and we can put it into a format for the decision aid and get an expert group to sort of give us advice about whether they're happy with like consensus on the format and content of the decision aid. We'll be developing then and testing the decision aid with that range of stakeholders, patients, healthcare professionals. And I would say there is a strong focus in this project with patient involvement within the whole of the research. So patient involvement really is crucial for this to be a success. The aspects of involvement, I've got a list there, but basically what I would say is that the patient involvement is in all aspects of this project really. We will have patients involved in the actual setup and governance, so they'll be part of the advisory group. We want patients then to be in that needs assessment process, like I say, the focus groups. Membership of the scientific reference group will include patients because we want people within that group to help co-design the actual decision aid, and who better than the people that will primarily use this. So then we will also need patients to help test and refine the decision aid, the usability and the field testing of the tool. They'll be crucial in that as well. So the outcomes then of this project, what we're hoping is that we will be able to synthesize and translate any research and evidence that we can on cancer care prevention, risk management strategies, and incorporate them into practice. And this tool is an aid within that process to help women when they come to their decision making. Ensure women have access to the information to meet their identified needs, and that is communicated in an acceptable and an interactive way. And provide individualized decision making support for women about which risk reducing strategies is suitable for them. We want more engaged, informed, women-centered decisions making really. And this is just a plug for the project now. So this is our ad that we've only, with the whole COVID situation, we've only really gotten back to having patients actually come to us in the clinics. So that's only started over the last few weeks. So we're currently in the process of recruiting anyone who's interested. So whoever's out there, my email was at the beginning of the presentation, and Carol is our family risk clinical nurse specialist, Carol Spillane, who will be instrumental in helping coordinate with people that are interested in this and giving information out. So her email's there as well. So this is just a little blurb about what the study is. It will be going online with various other agencies that are helping us with recruitment, and I think we have already linked in with a social media group who are very enthusiastic about. We've had quite a lot of interest from that group already, which is fantastic. So we're quite optimistic that there'll be quite a bit of interest in the participation of the study. And that's really it. And again, it's just to say thank you to the Irish Cancer Society for inviting me today and for funding this project that we are very excited about. So thank you. Any questions? I'm quite happy to answer.
That's great. Yvonne, thank you so much for that fascinating talk. It's really great to hear the progress that you've been making so far. And just as a reminder to everyone, if you'd like to answer some questions, there is a Q&A function down the bottom, so you can throw them in there and we'll get to them in order. So I might just kick off with my own question, if you don't mind, Yvonne.
Yeah.
Obviously, we're here digitally and the whole kind of world has been thrown upside down. What impact really has COVID had on people like yourself, like nurses and clinicians, to actually be able to do research?
Yeah, I guess it's like everything really, Chris. We've all had to sort of step back and look at the way we deliver care or carry on with what we want to do. Like you've carried on with your conference in this format, so which is fantastic. But it's been a challenge for sure. I mean, we have such large numbers, and that's one of the problems with COVID is trying to accommodate everyone that we want in the service. So clinically, I suppose one part of it is that we have done a lot of virtual. We were reluctant to stop anything for the high risk women, so we have had virtual clinics. We've carried on with imaging as much as possible. Oh, sorry, just a bit of yeah, sorry. I'm in a clinic. I'm next door to the clinic room. Sorry.
Absolutely fine.
But also, as far as the research, yeah, we did whatever we could remotely. You know, we have got a great researcher at the moment who is, you know, trying to get us to the point where we can start, you know, recruitment, which we are now, which we're delighted that we're not too far behind, but it has made us delayed us in recruitment, really. So we're trying to get going with that. But I think as far as focus groups, we've had to look at where we will be, because when we're in such unsure times, are we going to need to do those remotely? We'll be using facilities like what we have today. And I think that would be okay. You know, we have to do what we can with the times that we're in. But it's just made us all really step back and try and be a bit more innovative and keep going, really. You know, because we're going to have to keep dealing with this, I think, for the foreseeable future.
Brilliant, thank you. So we've a couple of questions coming in now. Two are actually really similar to each other, so from Robert and from Mary. So I'll read out Mary's. So she says, thank you. It's really interesting and valuable. You mentioned that at the moment there is not a lot known about the different BRCA variants. Perhaps variants have different weights in terms of risk. Do you envisage that if research in this area changes and progresses, you'll be able to implement that into the decision-making tool?
Yeah, no, I think that's a really good point, because yeah, I think that the whole point of this this tool is that, you know, we want it to be evidence-based, but absolutely in the future, if there's more known about the penetrance of a gene, for example, in a particular situation, then that should be incorporated into the evidence in the tool. So it will need to be updated. I think that might be what they may be asking, because it's not a static thing. There's so much we don't know about genetics, and the advancement of things like SNPs is going to change our interpretation of the risk that we associate with even BRCA1 or 2. There are new genes coming all the time. We have more testing happening all the time. We've panel testing now. And within those panels, there are genes that are emerging as quite high risk, actually. So we don't have too many within our service, but for example, there's a gene PALB2, which is quite high risk. So, you know, they're the sort of things that we would have to incorporate into this decision aid, because that's where the evidence is. Is that hopefully that answers that. But yeah, we do need to update it, and that would be where it would be a clinical tool that we are responsible for updating.
And do you know yet why there is a difference in risk between BRCA1 and BRCA2?
No, I mean, I think it's just because the more you test and the more you can see the cancer development. So it's like these new genes, the more we test and then we find out how they actually manifest in the future, then we'll know more about it. So yeah, I guess as time goes by, we'll probably know more as to why there's differences between the two. And I think the main thing there is that there are some protective genes that are being researched, and whether we'll be testing for that in the future, we're a way off from that. But in the future, I do think it will be much more defined. It won't be this blanket statistic that we use now, that we do know from the evidence we have, but it's not as defined as it could be.
Anula is asking, can you look at the mortality statistics a little differently? So, you know, in terms of actual the risk versus mortality, rather than the risk versus catching or getting cancer itself.
Looking at the mortality of women who are BRCA carriers.
Yeah, so I think in your slides you'd shown the risk of developing cancer, but not necessarily.
Yeah, I don't know if that's been looked at actually as an actual outcome. It's a good question. I guess the answer, it hasn't been looked at as far as I'm aware. I think what would be said is that it's not really an issue whether you're a gene carrier or not once you pick up a cancer. You know, it depends on the stage that you pick it up. But you would expect that the mortality would be better, because if you're in a high-risk surveillance program, the goal is that you pick up the cancer as early and as curable as possible. But I'm not sure of what the outcomes are as far as mortality. So we can look at that, but that's
I guess to follow on from that, obviously the women in your clinic are only those who are aware that they have the mutations, and I'm wondering, what percentage of the population who has the mutation are you actually identifying, and are there many women out there who will have a BRCA mutation who aren't aware that they'll have it?
So I suppose to answer that, we kind of find women who have a BRCA mutation from primarily their family history. It's probably the biggest marker of whether you may or may not carry that. So really it's a difficult one to sort of put a volume on, but we would do a lot of risk assessment within our service for women who are not gene carriers but are worried about a family history. I suppose in all the cancers that we see, there are actually very few that are mutate BRCA carriers. So in all the cancers that we diagnose, we feel about only 5 or 10% are actually gene carriers. So it's quite small. So the main way we find the gene carriers at the moment is either through their family history, and if they meet the criteria for testing, because there's a certain criteria that the geneticists look for, or if a woman has a particular type of breast cancer, she's very young, triple negative breast cancer, they can enter into genetic testing. So they're the main two ways we capture it. So it's a difficult one to sort of put a volume on, really, Chris, because unless we open up genetic testing to everyone, and that may be the future that we will, and we will be doing things like panel testing. We're not just looking at BRCA1 or BRCA2. Until then, it's a bit of an unknown quantity, to be honest. But the main source for us is how we identify gene carriers is women that are aware of the risk of that with their family history, or women who actually develop a breast cancer and then fit the criteria for testing. And some women get breast cancer and they have a family history, but they didn't really they didn't really feel there was a need for genetic testing. So there could be some public awareness there that is an issue that people aren't really looking at. I think it can go either way. Either some women are very aware of it and do something about it. Some women worry about maybe an unnecessary risk if they've got a very low risk family history, their grandmother, and that's it. But there's a thought that if I've got breast cancer in the family, I must carry this gene. And actually, like I said, it's very few women that actually are found to be gene carriers when we do test.
We've loads of questions coming in, and
okay.
so I'm sorry we won't actually get through all of them today, but I'll do my best.
Okay.
So Nikki's asking, when will you hope to have the toolkit ready for clinical use?
Well, the project is finishing in March 22, so shortly after that, really, so we're looking at another, I'm bad with this, 18 months.
That's great, it's not too far
yeah, so hopefully then, I mean, it will have gone through all the phases of developing and field testing. So once it's past that, then we will be hopeful it will be used. And that's for our area, and we would hope that if it's successful, then maybe other centres could use it as well.
So another question from Nuala. She was wondering whether the toolkit will take account of the other factors that you mentioned, such as family history, age, diet, etc. As in her experience, the risk has always been quite general rather than individual. So I guess you're kind of looking at kind of personalized medicine here.
Yeah. Yeah, we think we would like it to incorporate, lifestyle factors, those sort of things. There's a lot of research going into that now, as far as metabolic syndrome and things like that. So I know in St James's there has been quite a lot of research on the BRCA group actually and metabolic syndrome. So if the evidence is there, we'd like to incorporate it. But yeah, for sure, age is a big one. I think there's lots of things that can go into this that come up in the clinical area. For example, women who are using or are thinking of oophorectomy, if they're at that point in their families and at that age, the use of HRT comes up a lot. So there's sometimes a reluctance to use it, and then women feel they really struggle with oophorectomy premenopausally. It's a big thing to do. So I think yes. So lifestyle will come into it. Diet. I would envision all of that. If there's the evidence is there, we'd like to put it in. Yeah.
So Kieran asked, is there anything that women who may not have access to their family history can do to find out about their risk? So for example, people who would be adopted maybe, who wouldn't have that history.
Yeah, that is difficult. Yeah, adoption comes up quite a bit. So it's a difficult one for someone to come saying I'm adopted and I really don't know what my family history is. I don't know if they would offer testing in that situation, because you really are guided by with what's gone on in that family to determine whether genetic testing is appropriate. We've certainly had women who have developed breast cancer who are adopted, and they have been offered genetic testing sometimes, you know, or if you've sometimes a biological mother, if it turns out they found out they have a biological mother who had breast cancer but really don't know anything else about the family, there would be exceptions in that case. So it is a difficult one, adoption. So it's trying to kind of quantify what the risk is, bar blanket testing everyone. Yeah. So I don't know if that answers that really. So the answer is if you have an adoptive history with no information, that would be difficult to test in that setting. Sometimes it's very limited information when they find out some of their biological history, and there have been sort of some testing done in those situations, and for women who have cancer as well.
So I think we've probably time for just maybe 2 more questions. So Naomi has asked, if you're diagnosed with BRCA1, why are you not tested for BRCA2? I presume can you have both mutations simultaneously?
No, so you can't. So it's a good question, you know, because that comes up actually sometimes. So no, the answer is no, you would not. It's not compatible with life to have BRCA1 and BRCA2. I have I've been at a genetics meeting where one geneticist knew of a family that was the situation, and there was lots of unfortunate hereditary problems with that family, but for the most part, no, it's not compatible. So if it's BRCA1, it would not be viewed that there would be BRCA2 as well, if that answers that.
Great, and then maybe just one more then. So Rachel has asked, are you looking at other approaches in other countries? For example, the US lab Color Genomics, when they test, look at all the variants and genes as well as BRCA1 and 2.
Yeah, I think that is the way to go. Actually, that's the panel testing that I was mentioning, and they really, that's all they use in the States. I think the UK are also going more towards panel testing, and I'm pretty sure we will too. I think the problem in the past with those type of panels was that there's so many genes on those panels, so you could have up to 20 or 30 genetic flaws that they don't quite know what they mean, and that's what you would find the genetics people struggle with. Is if you find these some little flaw, I don't quite know what to do with that. So we know what to do with BRCA1 and 2. We're starting to know more about some of the other ones, and it's like I say, the more you test and the more you start seeing cancer patterns in those people, then we'll know more about the risk. So the ones that jump out at me from panels is PALB2, CHEK2 a little bit. There's some genes that are coming up and becoming a bit more noticeable with their risk. So I think the answer to that is I agree that probably is the way to go. It's not just BRCA1 or 2. Like I was answering in the other question, you know, when we test a lot of our patients that have cancer, we don't find BRCA1 or 2 mutations, even if we're expecting it. We only see it in about 5 to 10%. So there's definitely other genetic influences out there. And in the future, I think we'll be able to define that more. And hopefully in the future, even if you test for BRCA1 or 2, we won't just be giving you, look, you've got this 85–90% risk of cancer. We would hope that there'll be a bit more genetic information to guide us into what that risk means for you individually. You know, does that make sense? And if that's the case in the future, then hopefully this decision aid would incorporate that.
Brilliant.
Okay.
Like we could spend all day here with
Yeah.
all the different questions coming in. I have a list of 20 myself, but
Okay.
we have to end it somewhere.
Thank
So
you.
thank you so much, Yvonne, for your
Okay.
time today, and thank you everyone for attending. You may have seen the message there in the chat box, but if you've any questions that weren't answered today or anything that arises later on, please do feel free to contact research@irishcancer.ie or call the Irish Cancer Society nurse line on 1800 200 700. So this has been an Irish Cancer Society webinar with Yvonne Hanhauser for Cancer Week, and we thank you very much for attending. Bye, everyone.
All right. Thank you. Thanks very much.